is a repetitive test when you take pauses. Okay, other side. Perfect. Your handwriting is getting a little bigger as you get to there. Do you see it? See how small it is, and then it gets bigger, and it gets bigger, and it gets bigger. Right? You can even see where this ends, and then where that is. Right? You can see like your today here font, and then you can see it getting bigger, and bigger, and bigger. This is called macrographia. This doesn't really mean anything by itself. It just means your handwriting is getting bigger. Okay. And here we're looking to see if there's any like signs of tremor, like if there's any shaking, which you don't have. Okay. Macrographia may or may not be associated with cerebellar dysfunction. It's just one indication that occurs with cerebellar disease. We have to go in there and check other cerebellar findings, like her Romberg's test to see how her stability is. We want to have her do some tandem walking. We want to do some finger targeting tests to make sure she has smooth movements. Now, when she does Archimedes circles, we see that she doesn't have any indications of kinetic tremor. We also want to go in there and check some vestibular systems and see if her vestibular system is off. So the cerebellum has like a midline vermal pathway and then a spirocerebellar midline pathway as well. And those are involved with stability of the intrinsic spinal muscles, which impact balance. And there's also these midline vermal pathways that involve the vestibular-ocular reflex. The lateral part of the cerebellum is really involved with coordinating smooth movements of the limb. So as we check finger to nose and heel to shin, we can get a better idea if there's any kind of imbalance, there are any types of imbalances there. Now in a metabolic assessment form, we do see some gastrointestinal issues. We know she has some positive gluten testing. There's the possibility for gluten ataxia. We can also see in the brain region localization form, she doesn't have a lot of cerebellar symptoms, but she does have some cognitive impairment. And sometimes you can get people that have cerebellar dysfunction and can get patterns that mimic dementia as they start to have degenerative changes that occur in the cerebellum. The cerebellum is involved with motor calibration, but also plays a role in cognitive functions as well. When you're measuring blood pressure, the systolic blood pressure is letting us know the force the heart exerts on the walls during its contractions, and diastolic is during relaxation. Now with her, we can see that her blood pressure is normal. Now, we also check her blood pressure bilaterally to see if there's any difference in between the right and left. And the reason we're doing this is we want to see if there's any indications of peripheral arterial disease. Now, the heart is going to exert its pressure against the arteries, but if one artery has a different circumference because of calcifications, we may see a difference in blood pressure from one side to the other. With hers, everything is normal. So when we evaluate her perfusion index, we can see that it's ranging from 0.4 to 9.1, but it really averages really in the 0.8, and this is very low. So perfusion to her tissues is low, and then when we look at her pulse ox, we can see her pulse ox is 100%, which is great, and her heart rate is 70, which is healthy. Pick refill time was pretty good. Temperature's there. Okay. It's your skin. Let's look at your toenails. On the bottom of the feet. There's no signs of peripheral, like, well, remember I said you might have peripheral arterial disease or something? You have discrepancy. They look fine. Is 87 up here? 80, yep. Yeah, it's a 13-degree difference. So it's pretty equal left to right. Well, yeah, let's see here. 86. 85.1. There's a difference between right and left. Let's check right here in your elbow. Cubital fossa here. 89.6. That's symmetrical. Let's check right at the wrist. Yeah, there's a difference between right to left. 2.3. Yep, there's a difference between temperature between right and left in your arms.
Oh, so that's one of the things for your peripheral that you're saying?
Yeah. Okay, let's just check your temperature over here. Yeah, let's look at your right at your ankle there. So when we examine her extremities to see how her circulation is doing, we can first see that her skin color looks okay. Her nail beds are a little bit paler, but she does have nail beds that do have pink in them and there's blood flow in them. Her capillary refill times are normal in both her hands and her feet. I look at her legs to see if there are any signs of peripheral arterial disease. With peripheral arterial disease, you'll sometimes see ulcers and injuries that just don't heal because of poor blood supply. So we don't see any obvious signs of peripheral arterial disease. Now we do see some differences in circulation and temperature, which are important to us. When we measure her surface temperature, we can see first of all that there's a 4-degree difference between her right side and her left side. And the other thing that we see that's important is, she's got poor circulation. There's a 13-degree difference between her proximal distal tissues in the extremities, in the upper extremities and the lower extremities. There's 11% difference there. So usually anything more than 10% difference between the proximal and distal tissues lets us know that there's poor signs of poor circulation. So there's a little bit of circulation aberrancies between one side and the other, and not the best circulation from proximal and distal. This doesn't indicate that she has peripheral arterial disease, but it lets us know her circulation's off. Now, this could be some of her past thyroid patterns that were never addressed. That could be an issue. It's just a sign of poor circulation, but not necessarily associated with arterial disease. Your pulse strength is equal. So let your arms relax a little. There you go. Behind your knee. Okay. So with her medical history of having differences in temperature between right and left extremities, again, there's always the possibility of having some peripheral arterial disease. So as part of the vascular examination, we're really looking at her pulse, strength, and amplitude in her different tissues. And one of the things that we're doing is we can see that I check her radial artery pulse, her brachial artery pulse, her dorsalis pedis pulse, and her popliteal artery pulse. And everything feels exactly the same and symmetrical. There's no difference in pulse strength, amplitude from one side to the other, which indicates everything with her pulse is normal. And then the other side. Okay, nice and pink and healthy. Especially in her eyelids, you can see that there's no signs of pallor. They're nice and pink. This is important. It's usually when people have anemia and poor red blood cell health, you'll see really pallor in her eyelids, but hers are nice and healthy. Okay. I'm just going to stick your head back so I can have it pop out more. Can you extend your head more? There you go. Then I'll turn your head. Just to see if there's any growths or any kind of nodules. And it looks okay. And I'm going to bring your head down a little bit. Bring your head like this. And there we go. Go ahead and swallow. Okay, so most fine. Great. I'm just going to palpate your lymph nodes.
Mm-hmm.
So you can see with thyroid inspection, there's no displacement of her trachea or thyroid gland. There's no signs of enlargement. There's no asymmetries. And then palpation of her thyroid gland was totally normal. There was no nodules or masses felt. And then her lymph node examination was also normal. There's no enlarged lymph nodes noted during palpation. Okay, let's listen to your heart. Go ahead. Deep breath in and out. Deep breath. And out. Okay. Deep breath in. And out. And just keep doing that every time I move it. A little deeper in and out, please. Out. And out. Let's just listen here. See what? Again. Out. In. Out. In. Out. In again. Out. One more time. Again. In. Out. In. Out. In. Out. And again, in, out, in, and out. Okay, so auscultation of her neck and heart are totally normal, and we don't hear any abnormal sounds with the carotid arteries, no bruits. Her heart auscultation is totally fine, but when we listen to her lungs, she has an expiratory wheeze, and you can actually even hear it when she takes some deep breaths in. And this is an indication that she may have some mild pulmonary obstruction that's occurring, and most likely associated with her history of asthma. So we know there's some types of environmental allergens that may be playing a role in her overall oxygenation and health. Now, unfortunately, we didn't, it's not on the camera here, but we repeated her pulse ox, and after some deep breathing, her SpO2 levels were down to 96%, and then throughout the exam they went back up. But there were some periods where her SpO2 levels were lower than they should be, which is an indication that she's having these, asthma constrictive responses even throughout the exam. So there's definitely some environmental allergens. We need to do some IgE testing to identify and see if we need to remove those triggers to calm down her immune system. Yeah, it's a mild obstruction. So with the spirometric evaluation, we found that she had some mild pulmonary obstruction of about 40%. This is, again, an indication that her asthma is impacting her ability to oxygenate her system. It's uncomfortable for you, okay? I'm going to push you around. It's going to tap. So auscultation of her abdomen was totally normal. She had nice bell sounds. Percussion, palpation were normal. There was no areas of sensitivity. There's no signs of any organ enlargement. But one of the things that was important to note was that she really has very limited muscular tone, and she really had virtually no abdominal muscles to contract through. And we did her BMI. Her BMI was low. She's underweight. She really has no muscle mass. Now, it's hard to see that during the examination video because she's wearing a really baggy clothes, but she definitely has very little muscle mass, and her body is just extremely soft, not just in her abdomen, but also in her limbs, which lets us know that she may even have, a little bit of increased body fat. She looks like she's normal weight, but it's really due because of the fact that she has such little muscle mass itself. That makes you dizzy at all? Dizzy at all?
No.
Okay, other side. You dizzy at all?
No.
So the decline test really evokes stretch on the vertebral arteries, and if people have any type of vertebral artery calcification, this extension and rotation can decrease blood supply. We can see patients develop nystagmus and even dizziness if that's occurring. With her, we don't see any imbalances, and sometimes when people have their head put in this position, they may also get dizziness, but again, everything's intact with her. Here you can see me conduct an ankle-brachial index test. So I'm using a Doppler to get an accurate measurement of her systolic blood pressure in her arms and feet. And once you identify the blood pressures in her arms and feet, then you basically do a calculation. You take the pressure in the foot divided by the pressure in the arms, and then you get a number. And the normal ratio is 1.0 to 1.4. So her AB index was 0.95. So this is below the normal reference range. So this may suggest some very early patterns associated with calcified vessels or peripheral arterial disease. Now, we may want to have her go and get some further testing with like a venous Doppler study to really confirm if that's there. But it's definitely something to keep an eye on.
Oh, my.
So PQRS complex is normal leakage. Great. In this part of the exam, I'm just going through an electrocardiogram evaluation, and she has a normal sinus rhythm, and we can see that her heart's rhythm and electrical activity is all normal and healthy.
I mean, it smells like.
Try the other side.
Yeah, chocolate, coffee.
Okay.
Coffee. Yeah.
Was it the same on both sides?
I think so, pretty much. This was stronger, the left side, but
You can still smell. Try to see if you can pick up what this is.
fennel type.
Yeah?
Fennel. I don't know. People in general would know fennel even.
Yeah.
So that's yeah.
I
eat
is it the
fennel all the
same
time.
both sides?
Yeah.
Okay.
I think so. Yeah. I can smell, but I don't know what it is. I may not know the
Try
spice.
the other side.
Yeah, I don't know this thing.
You sure it's very exotic? I'm joking. It's mint.
Oh, I don't eat mint
There you
because
go.
of because
But
of
you
the,
smelled it.
But I smelled it. It
You
kind
smell
of
it? Yeah. How about here? You smell it?
okay.
Double?
I have to because when I'm talking, I'm distracted. But the smell was not too strong.
As soon as you smell, just raise your hand. Right there? Okay. Other side. Okay. So the olfactory evaluation and peanut butter sniff test can be used to evaluate olfactory or cleaner nerve 1 integrity, but they can also be used to screen for neurological diseases as well. So peppermint, anise, and coffee are the first scents that tend to be compromised with Parkinsonian disease. And with her, she's able to recognize the scents. She wasn't able to recognize it was mint, but she was able to notice the scent, so we consider that normal. And the peanut butter sniff test looks for significant asymmetries between one side or the other, which two studies have now shown could be a early risk factor for dementia, since the pathways for olfaction are linked with areas of the medial temporal lobe that is associated with early degenerative changes that take place in Alzheimer's disease. But with her, everything was normal. What does that taste like?
Salty,
Okay,
sweet.
perfect. Okay, here you can see that taste perception was normal. She was able to recognize different tastes. If it's the same contrast with that one eye versus the other.
Contrast. Oh, colors. You mean?
Yeah.
Yeah, that's fine. Yeah.
Same?
But this eyesight is weak. Fine.
That's fine.
Okay. Yeah.
The contrast colors are the same.
Yeah. Same.
One of the things you can quickly do to evaluate integrity of the occipital lobe is just to look for color perception, if the difference in colors are the same from one eye to the other. And with her, everything was intact. Just look over here. Look at that.
Oh.
There you go. Perfect. Look over the other way. There you go. The corneal reflex is a great way to check for sensory efferent pathways of the trigeminal B1 nerve root with the efferent component of muscle contraction of the facial nerve, kind of nerve 7. This really looks for integrity of that upper brain stem region, and everything is intact. Do you feel that?
Yeah,
Okay,
yeah.
point to it. There you go. And you can just tell me if it gets harder to point. So you can just tell me where it is.
Oh, under my feet. Under my feet. On the right side here. Oh, sorry.
No problem.
Down under the ankles or knees. Down under the knees.
Okay.
Yeah, front.
Does this feel the same as that?
This one is sharper.
Let me do that again. I think I got stuck in there. Is that the same as that?
This was almost the same, yeah.
Okay, almost as.
Same.
Okay.
Right side a little bit. Yeah, I think right side is a little bit more. It's kind of same, maybe
I'm not
1
gonna-
degree
I'm gonna
different. Same,
try. Same. Okay.
same, same.
Hold on.
Oh, maybe
Say
a
that
little,
again.
a little bit more, a little bit more. Yeah, a little, maybe, you know, a little more on the right side. Same, I think, just slight more.
On the right side.
Yeah, same kind of. Same. Yeah. Nothing significant to really say that.
Yeah.
You
Let
know.
me check. Feel what that is. What is that?
It's like some metal round. Oh, battery.
Okay. Wonder about something in your left hand. Go ahead and feel what that is.
Oh, this is that paper clip.
Great. We're going to call your pointer finger number 1. This is number 2. This is number 3. And that's number 4.
Okay.
Okay? Close your eyes. Which finger am I touching? Which number?
2, 3.
Okay. Now don't move your hands at all. Which one on the left?
Right is minus left. 3,
Which one on the right?
2.
Okay. Feel this. Feel that?
Mm-hmm.
Does it feel the same?
Mm-hmm. Mm-hmm. Yeah. Same. Mm-hmm. Mm-hmm.
Same? And that's number 2.
Yeah, the 2 is colder.
This is number 1. This is number 2.
1 is colder.
This is number 1. This is number 2.
2 is colder.
Here's 1. Here's 2.
1 is colder.
Here's 1. Here's 2.
2 is colder.
1, 2.
1 is colder.
1, 2.
1 is colder.
1, 2.
1. No. 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 No.
Okay.
Left ankle. Yes.
Yeah, try not to move it.
Oh.
Visualize your right ankle.
Uh-huh.
Is it as easy to distinguish left and right ankles? Where they are in space? How you feel?
I mean, I can. Okay, so I can distinguish that where is my left and where is my right.
Right. Is the perception harder on one side or the same?
I think I have to think. You know, it
Sure.
doesn't come intuitively.
Right.
It's not like, okay, here's my left. I have to think, and yes, then it's fine.
Okay. Do the same thing with your left elbow and right elbow.
Okay,
Same?
fine. I think it's better with my elbows actually.
Okay.
Than
The left and right is the same.
yeah.
Okay, great. So in this part of the examination, we're doing a sensory examination. We're checking light touch, pinprick, vibration perception, extinction, temperature perception, monofilament, and limb position sense. And this is evaluating the integrity of our C fibers or A delta fibers and areas of our somatosensory cortex. And for the most part, everything is totally fine. Just a little bit of increased sensation on the right side, but when we do other types of sensory testing, we don't see any other findings, and it was just very subtle and it's nothing that's clinically significant. Now, the reason I wanted to do a really detailed examination here is because, with your history of having different temperature sensations, it could be vascular, and we do have some early indications of peripheral arterial disease. But sometimes when people have spontaneous activity of their parietal lobe, whether it's from degeneration or traumatic brain injury or even some kind of epileptiform seizure activity, people sometimes perceive movement and temperature differences and sensations in their limbs that may not really be there, but they perceive it because the areas of the brains are firing. And if those types of imbalances were occurring, we may have seen some abnormal examination findings with these tests, but everything was intact. The light bulbs hitting your eyes. So the light reflexes directly in the middle of the pupils. It may look asymmetrical because of the eyelid differences between left to right, but the eyes are aligned with the pupil light reflex. Okay, go ahead and open your mouth. Your tongue. Go ahead and say ah.
Ah.
Great, I'm going to just check your gag reflex. Great, sorry. Just going to check your saliva production. You can bring your tongue back. Nice saliva. Nice and shiny. Great. So the pupil light reflex is normal. The light's hitting her pupils exactly the same spot, so we have no ocular misalignments. And then we get into the mouth exam, and you can see that her mouth, first of all, has a lot of saliva, which means her parasympathetic activity is nice and healthy. She has nice pink color in her cheeks. Her gums are nice and healthy. Her teeth are nice and healthy. She doesn't have any missing teeth. She has really good dental hygiene. And then when we check her gag reflex, we see her palate move, and we see that she has a normal gag response on both sides. So all these things let us know that she's got some integrity of her vagal functions, producing saliva, and also being able to digest from a neurological perspective. And these are all good signs for us that there's no neurogenic mechanisms that may be playing a role in her gut dysfunction. So with the panoptic ophthalmoscope, I'm just taking a look into her eye, doing a fundoscopy, and we can see that her eyes are nice and healthy. She has really good vasculature in her eyes. Her retinal arteries and veins are healthy. Her optic cup is healthy. Her macula is healthy. Her optic disc has very clean, nice borders. We see a nice pink tone of her eye. We see no signs of protein accumulation or any signs of microvascular disease. So really good findings with the anatomy and structures of her eye. Just going to look at your sinuses. Nice. Perfect. And tilt your head back. Just going to look at all the way back and look at your nose. Nostrils there. Okay. So we see no signs of sinus congestion. Sinus illumination was normal. Sometimes when people have asthma, they may get sinusitis and sinus buildups and congestion there, but with her, everything looked nice and healthy. Her septal exam was normal, and everything was aligned. No indication that there could be some breathing abnormalities with her septum anatomy, which is important since she had some respiratory obstruction issues with her asthma, some expiratory wheezing, and some about 40% obstruction of respiratory examination. So it's good to see that her septum is nice and healthy, and there's no manifestations of any allergic or immune-related issues with her sinuses. Just going to check the tone. Sure. give you a stretch. So in this part of the exam, we're checking her motor system, we're evaluating her muscle tone. Her muscle tone is intact on both sides. There's no signs of spasticity or rigidity or knife clasp deformity, which you may see with certain neurological diseases or any type of dysfunction in her brain or any kind of peripheral motor diseases. So everything's nice and healthy there. Her deep tendon reflexes are intact. Then we go through and check upper motor neuron signs in her upper and lower extremity to see if there's any type of injury or demyelination anywhere from her cortical spinal tract all the way down into her anterior horn, and everything's intact. There's no positive upper motor neuron signs, and we can see that she doesn't have any signs of clonus. So that exam literally took 1 minute to conduct, so you can do a very rapid, quick assessment of the motor system if you just have your sequence in order of just going through all the tests that will help you identify dysfunction in that system. As fast as you can, all the way open, all the way closed. Perfect. And I want you to do this. Finger one, finger two. There you go. Go as fast as you can. Now do the right side as fast as you can. Just once each.
Oh, yeah.
Other side. Okay, perfect.
That way I'm sitting.
And then other side. Okay. So we're conducting a rapid motor testing, and what we can see here is that her speed and her accuracy and her ability to initiate and stop movements are all intact and healthy. So this is obviously a great evaluation to look at motor planning, premotor areas, the basal ganglia, the cerebellum, and with her everything seems to be nice and symmetrical from one side to the other, and her speed and coordination and amplitude and timing is all normal. And all the way straight down. Other side. Okay, do one more time. This time eyes closed. Okay. Heel to shin testing evaluates the ability for the cerebellum to turn muscles off and on in sequence. It's equivalent to the upper extremity supination pronation test. So with heel to shin, if the cerebellum is doing its job properly, then the person can accurately touch their heel to their kneecap and then go down the shin smoothly without any shifts or movements. And with her, everything was normal. And then this way. There we go. I'm going to move it.
Oh, I see. Okay.
And do it vertical. Look straight ahead. Okay.
Yes. Yes.
Don't move your eye.
Yes. Yes. Yes.
Look the other side. I'll cover the other eye. Look straight ahead. Tell me when you see it. Don't look. So you should look over here.
Oh. Yes. 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 Yes.
So a neurological evaluation of eye movements can tell you a lot of what's happening with a person. Now, we start with cover-uncover tests just to make sure that we don't have any eye muscle weaknesses, and then we check her cardinal fields of gaze by having her track the pen with her eyes. And these are just pursuit activities, and they check the integrity of cranials 3, 4, and 6, but they also check the integrity of the areas of the cerebellum and the frontal eye fields, and also different areas of what's called the parietal and vestibular cortex, and those are all intact. Then we have our target with her eyes quickly. Those are called saccades. Saccades are a good way just to evaluate frontal lobe activity planning, speeds, or a key factor of frontal lobe issues. When people get frontal lobe injuries, you see their saccades become really, really slow. Now, hers were not the best saccades, but they were not anything to worry about. And then we check her optokinetic reflex by looking at that red and white tape, and we see she should see those nystagmus type movements, which we do see with her. And then I spend a lot of time doing a careful visual confrontation test, and sometimes when you see very diverse hormonal weird symptoms that could be vascular, endocrine, you're really not sure what it is. There's a possibility that there could be something subtle like a prolactinoma that's putting pressure on the pituitary and optic pathways. The anatomical structure is putting pressure on these optic tracts, but the prolactin levels that are released by these benign tumors are really what disrupt hypothalamic endocrine feedback loops. It can disrupt TSH, FSH, LH, and just cause complete hormonal disruption and nervous symptoms everywhere. And sometimes you'll see that with their visual field loss, and typically when the compression takes place, it hits the lower fibers, which cause a person to lose their upper visual field when you do the confrontation test. Now with her, everything was normal. And then we concluded the test with Virgin's testing. So you can tell a lot about what's happening with someone's physiology with just a quick neurology of eye exams, and also the confrontation test, is a good way to screen for potential prolactinomas that are more common than you may think, that sometimes cause very weird, diverse symptoms, but with her, everything was intact.
Oh,
There you go. That again. Okay. Now don't blink. So we'll have the patient look directly in between my eyes on her nose on a target, and I move her head back and forth. I'm just looking at her vestibulocaudal reflexes. And then I do what's called a head impulse test. I quickly bring her head back to center, and her eyes should immediately come back and not bounce around. And if they bounce around, there's some indications that there could be some disease involving the cerebellum, whether it's neurodegeneration or autoimmunity or something that's causing dysfunctional activity of the cerebellum. We can see that with the head impulse test. And then I went through and just did a quick glabellar reflex. So you ask the patient not to blink, you tap your glabella, and with her, everything was normal. With people that have to blink when you tap it and have to blink when you tell them not to blink, that could be an indication of early basal ganglia disease and dysfunction. And with her, everything was intact. And then walk back. There you go. Come on back. This time when you walk back, I want you to do the alphabet out loud, but every other letter. A, C, okay? And just keep going.
A, C, E, G, I, L, N.
Walk back. Start with B.
B, start with B, and then still another.
Yeah.
B, D, F, H, K.
Okay. So you can see with her evaluation, her gait and her ambulation is normal. She doesn't have any sways or falls to one side. She doesn't have any abnormal posturing. She has good arm swing. She has good leg swing. They're pretty much symmetrical from one side to the other. We have her double task. She has a little bit of slowing, but that's within normal limits. And then she is able to ambulate properly. So she seems to have stability. She doesn't have any issues with stomping her foot to the ground. There's no sensory impairments. There's no shifts of body position or movement. There's no abnormal head position. She's not staring at the ground to walk. So all these things let us know that she has good integration with areas of her nervous system involving her motor function, her sensory system that's necessary for ambulation. As fast as you can. All the way up, all the way down. Perfect. And then bring your elbows in. Do the same thing. Perfect. Bring your hands out. I need to see your nose because you got to touch your nose. Okay, put your hand up. And then I want you to touch your nose with this fingertip. Eyes closed. Bring your hands out again. Touch your nose. Let me touch the finger. Close your eyes. This one. Perfect. This one. This one. This one. Go a little slower. Okay, great. So you can see with her rapid motor testing that her movements are fluid. They're symmetrical from one side to the other. We don't see any signs of dysdiadochokinesia. We don't see any freezing. We don't see any rigidity. Everything looks perfect. And then we did a targeting test. She goes finger to nose. For a second, it looks like she has a termination tremor. But then when we have her slow down and just do the test appropriately and do it repeatedly, everything is fine. So this lets us know that areas involved with motor activation planning, calibration are intact. And then her targeting tests, which involve cerebellum, parietal function, and sensory perception, are all functioning very well. Okay, close your eyes and try not to fall or move. Perfect. Go ahead and put one foot in front of the other. Stay right there, eyes open. Keep your balance, eyes open. And close your eyes. Good, eyes open. Do the other leg. Switch to the other way.
On.
Bring this foot forward. There you go. Eyes open. Try to keep your balance. Close your eyes. Perfect. I want you to walk in a straight line for a few steps.
Eyes closed or
Eyes open.
Okay.
Put arms to your side. Perfect.
Yeah, you can move.
Okay.
It's okay.
Go ahead and close your eyes. And then go ahead and do it.
Oh.
Perfect. Okay, put your feet together. I'm going to give you a little pull. Stay right there. Don't let me pull you. Close your eyes. Do that one more time. Keep your eyes closed. Okay, perfect. So in evaluator balance that we can see that her Romberg's test is negative, her tandem Romberg test is negative, she can walk in a straight line, she can walk tandem. These are all great. You should always check balance with anyone over the age of 50 since falls or leading cause of death. And the other thing we did is we did a pull test at the very end. In the pull test, you have the patient close their eyes and you give them a little tug and they should be able to stop themselves from falling within 3 steps. And she had 4 steps and repeated it, and it was positive. And this is one of the things that is used to evaluate postural reflexes with Parkinsonian disease, but usually you get much more trembling and titubations when that happens. It just happens to be 1 step off, but we're not considering that a significant finding. So overall, we can see really good parameters of balance with her. The same too?
Yeah, same.
Okay. I'm going to place this tuning fork on top of your head. Tell me if you hear it sounds equally, okay?
It's lower here, it kind of goes down, right, the sound?
Is it different between left and right?
But you kept it at the same place.
Yeah. Is it equal? You hear the sound equally? Left and right?
No, I didn't understand the question.
So tell me if you hear the sound more in one ear or the other ear, or if it's the same. I'm going to put this on top of you.
Yeah.
Tell me if the sound is the same between left and right.
Okay.
Do you hear it equally in both ears? Or do you hear it more in one ear?
You know, I can't really tell the difference between the two.
That's
ears.
right. Okay. Which one's louder? Number 1 or number 2?
Or number 2.
Which one's louder? Number 1 or number 2?
Number 2.
Perfect. Okay, great. It's hypermobility. So otoscopic evaluation indicates she has very healthy, clean eardrums. There's no signs of any perforation, scarrings, or lesions. We check her hearing is normal. When I go through and test her with a nymphantograph and look at the movement of your eardrum or tympanic membrane, you can see that it's a little hypermobile. And these overly mobile tympanic membranes can sometimes happen if there's been some type of injury or loss of elasticity from a perforation of the eardrum. But there's no signs of that with visual inspection. Sometimes people just have, increased mobility of certain joints. Sometimes it can indicate like a genetic Ehlers-Danlos syndrome. There's no signs of that with her.